Greetings. Let us learn about chronic pancreatitis with a focus on diagnosis of exocrine pancreatic insufficiency. We have learned that the pancreas has an exocrine compartment that secretes enzymes and an endocrine compartment that secretes hormones and are important for glucose homeostasis. So in this, we'll focus on exocrine pancreatic insufficiency. I'm grateful to my mentor, Dr. John Stroline, Mr. Charles Butt, Miss Angela Deal, my institution, and my mentors. Please read this notice. So let us take an example. And if you eat a Big Mac, it consists of bun, that is carbohydrate, a protein patty, and cheese, that is fat. And once you take a bite, the digestion starts in the mouth with the help of salivary amylase. That is, the carbohydrate digestion starts in the mouth. And as the food goes down into the stomach, and the stomach grinds the food, and along with the help of hydrochloric acid and pepsin, protein digestion starts. And with the help of gastric lipase, fat digestion starts in the stomach. So carbohydrate, fat, and protein digestion starts by the time the food is emptied into the duodenum. Pancreas plays a major role in completing the digestion of carbohydrate, fat, and protein. So pancreas secretes enzymes, and these pancreatic enzymes could be categorized into carbohydrate digesting enzyme, that is amylase, fat digesting enzyme, that is lipase, protein digesting enzymes, a bunch of them, trypsin, chymotrypsin, carboxypeptidase, DNase, and elastase. A bunch of them are helpful in digestion of the protein. So all of these enzymes, along with the bile, help in the digestion. And once the Big Mac, the carbohydrate, the protein, and the fat are broken down to monosaccharides and disaccharides from carbohydrates, that is a starch, free fatty acids and monoglycerides from the fat, and individual amino acids from the protein. And these are the components that are absorbed by the small intestine. So, say for example, how do you assess whether a pancreas is producing enough pancreatic enzymes? And you can check in the stool for elastase, fecal elastase. We use fecal elastase because among all the pancreatic enzymes, fecal elastase is very stable and it can be measured easily, and this is routinely used to assess whether a pancreas is producing enough pancreatic enzymes or not. If fecal elastase is more than 200 micrograms per gram of stool, you know that the pancreas is producing enough for digestion of the food. Next is digestion. How do you know whether the pancreas is secreting enough enzymes to digest the food? In this case, you measure how much of the fat that we eat is absorbed after being digested by the pancreas. And what we do is we collect the stool after giving the patient 100 grams of fat for a few days, and then collect the stool for 72 hours and look at how much of the fat out of the 100 grams per day is being excreted in the stool. The coefficient of fat absorption in a normal, healthy individual with a well-functioning pancreas is more than 93%. So majority of the fat that we eat will be digested and absorbed. So less than 7% of the fat that we eat is lost in the stool. So if you take a healthy individual and put them on 100 grams of fat per day for several days, and then measure the stool for 72 hours and check how much of stool fat is lost, should be less than 7%. So this is an indirect way to figure out whether the pancreatic enzymes are doing their job. That is the digestion. We also know that fat-soluble vitamins also need pancreatic enzymes for allowing them to get absorbed. And you could also check in the blood fat-soluble vitamins A, D, E, and K. And if the pancreas is working well, enough pancreatic enzymes with normal digestion followed by absorption, you should have normal levels of fat-soluble vitamins in the blood. So when you think about pancreas evaluation, exocrine function, think about enzyme output, that is fecal elastase, digestion, that is how much of stool fat is lost, how much of fat is lost in the stool because of not having enough digestion. And then the other thing is whether it's the food products are being absorbed after going through the process. In the blood, you can check fat-soluble vitamins. So with this normal physiology, let's apply and see what happens in a patient with chronic pancreatitis. In chronic pancreatitis, there is damage to the exocrine compartment, that is acinar cells, and as well as ducts. So there is very little flow of pancreatic enzymes coming into the duodenum. That means less digestion and less absorption. So when you know this, so if you want to check, hey, is the pancreas secreting enough enzymes or not, you check the fecal elastase. If it is less than 200 micrograms per gram of stool, you know that the pancreas is not putting out enough pancreatic enzymes. And the effect of not enough pancreatic enzymes is you don't digest the fat. So more fat will be lost. So a coefficient of absorption will be less. So in this case, coefficient of fat absorption will be less than 93%, or stool fat will be more than 7%. We also know that if there is not enough pancreatic enzymes, less digestion and less absorption of fat-soluble vitamins, that means your blood level of fat-soluble vitamins will be low. So these are the concepts you want to keep in mind. These are simple concepts. And let us go one step further to figure out how bad is the exocrine pancreatic dysfunction. So you take the values of fecal elastase, stool fat, that is coefficient of fat absorption, and then fat-soluble vitamins. We know that unless the pancreatic insufficiency is very bad, you don't develop fat-soluble vitamin deficiency. And unless it is a little bit less damage, but fat-soluble vitamins are getting absorbed, you can still have loss of fat in the stool. Sometimes you may have pancreatic dysfunction where you not have enough enzyme output, but sufficient to still digest fat and retain, absorb the fat. So you keep those things in mind. Let us look at it. So in stage 1, very mild exocrine pancreatic dysfunction, your fecal elastase will be less than 200, but patient is able to digest and absorb fat as if it was normal, to the normal level. So their coefficient of fat absorption will be more than 93%, or stool fat will be less than 7%. And we know that fat-soluble vitamin deficiency happens very late with very low levels of pancreatic enzymes. So in stage 1, your fat-soluble vitamin level will be normal. Let us go to stage 2. In stage 2, fecal elastase output comes down below 100, and they may have still normal coefficient of fat absorption, or in some cases, coefficient of absorption of fat may come down from 93 to 85%, anywhere in that range. So this group, if the fat absorption is normal versus decreased with symptoms, is something we will talk about it. But in this stage 2, your fat-soluble vitamin level will be normal. How about stage 3? Here, the pancreatic insufficiency has become much more severe, much less output of pancreatic enzymes. So fecal elastase is below 100, most likely even less than 50. And their absorption, coefficient of fat absorption has dropped to below 85%. So in these patients, when you look at stool fat output, it will be 15% or more. And in some of these patients, they may have low normal fat-soluble vitamins. And finally, in extreme cases, stage 4, your fecal elastase is low, pancreatic output is low, enzyme output is low, fat absorption is low, less than 85%. That means they have stool fat content of 15% or more. And because it's extreme, they have also lost the ability to absorb fat-soluble vitamins. So in this case, your vitamin levels in the blood, A, D, E, K, will be low. So how do you use this to figure out which patients are you going to put them on pancreatic enzyme therapy? So that is the most important thing. When it comes to pancreatic enzyme therapy, keep this thing in mind. In stage 1, even though they have less pancreatic enzyme output, they're still able to manage and absorb fat well. Their coefficient of fat absorption is pretty good, more than 93%. They don't have any fat-soluble vitamin deficiency. In this case, there is no role for pancreatic enzyme therapy. On the other hand, if you have low fecal elastase that has resulted in fat malabsorption, that means the coefficient of absorption has dropped below 93%, and they have symptoms. In this case, you may want to try pancreatic enzyme therapy to see if the symptoms improve. A trial is what we do here. On the other hand, when you notice that a patient has fat malabsorption manifested by coefficient of fat absorption of less than 85%, or if their fat malabsorption is associated with low vitamin levels, these are the patients for sure need pancreatic enzyme therapy because their pancreas is not able to produce enough enzymes to help with the digestion of the food. And in this group, for sure, they need long-term pancreatic enzyme therapy. So having this in mind, how am I thinking through my patients? I'm looking at fecal elastase to give a rough idea of how much pancreas is producing in terms of the enzymes. Then I'm looking at enough enzyme for digestion or not. So look at stool fat. And also look at whether it is impacting absorption of fat-soluble vitamins. So when I see a patient with chronic pancreatitis, CT shows changes of chronic pancreatitis, as gland atrophy, calcification, ductal stricture, ductal dilation, stones, etc. I will do the fecal elastase is low, less than 100. And then I also take into equation what is happening to fat absorption. And by doing a stool test, 72-hour stool fat, and fat-soluble vitamin levels in the bloodstream. So simpler to do is I will do it in reverse way. If I have a patient with chronic pancreatitis on CT, I would simpler to do fecal elastase because it's not tedious to collect a small sample. And then I will do blood levels of fat-soluble vitamins. If both are low, that means it's already stage 4. I can put the patient on pancreatic enzyme therapy. On the other hand, if the fat-soluble vitamin levels are normal, and then I want to decide about pancreatic enzyme therapy, then I will convince the patient to go through the 72-hour stool fat collection and measure the coefficient of fat absorption. If it is less than 85%, for sure I'll say this patient will benefit from long-term pancreatic enzyme therapy. On the other hand, if it is borderline between 85 to 93%, I will tell the patient, hey, let us give a try, and they have symptoms, discomfort, bloating, a little bit of change in the stool consistency, sticky stools, foul smell, etc. Then I will tell the patient that let us give a trial of pancreatic enzyme therapy to see if the symptoms respond, and if they respond, then consider long-term pancreatic enzyme therapy. I hope this is helpful. Thank you.